Welcome to Deep Dive Dialogue. Our topic of discussion today is managing high risk pregnancy, prenatal screening for genetic disorders. Managing high risk pregnancies involves comprehensive prenatal screening for genetic disorder, allowing early detection and intervention. This proactive approach is crucial for optimizing maternal and fetal health outcomes, ensuring informed decision making and personalized care. Our panelists for today's discussion are Dr. Bipaskar, PhD, consultant geneticist and molecular medicine, Department of Laboratory Medicine, Kokilabhai Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. Dr. Vandana Bansal, Director and Senior Consultant, Obstetrician, High Risk Pregnancy in Perinatology, Department of Fetal Medicine from Surya Mother and Child Hospital, Santa Cruz, Mumbai. A very warm welcome to our panelists.
Thank you for your kind introduction, Dr. Monisha. Thank you.
So my first question is for Dr. Vandana. Which pregnancies are considered as high risk? What are the routine antenatal evaluation in low-risk pregnant women? And is the follow-up and investigation different from high-risk pregnancy?
So if you look at it, high-risk pregnancies are pregnancies where we have a higher risk of either having a fetal or a pregnancy complication. This could be either maternal or fetal in origin. So basically, there are a lot of factors which lead on to these high-risk pregnancies, which maybe we will go on as we go further. But yes, low-risk patients are also at risk. So we can't just say that high-risk pregnancies only need to be managed and the low-risk can be left as such. So when you say that what are the routine evaluation in a low-risk pregnant women, we still need to do most of the tests which are done in high risk. Only thing is the sequence and the frequency of doing tests are more in high risk pregnancies. So in a low risk pregnancy, when a patient comes for the first time, we expect them to at least come in the first trimester. And the first visit that they come to us, we need to take a history to understand whether they are high risk or low risk. So we go through the history, look at her previous obstetric history, then also whether she has any medical disorders, what is her age, look at her blood pressure, do a clinical evaluation to see for her general health, also look at the weight of the patient. And then we would want to now do some investigations in this. So for a mother, we will do a first, most important in India is to look at the hemoglobin. So a CBC count that she is not anemic is the first thing to do. Sugars are very important, and because you have high sugars, you could have malformations more often. So your baseline sugars in the first trimester is important to know whether she is not already diabetic. Then we have blood group, which is important because if it is Rh negative, we need to know the husband's blood group. And if it is positive, then there are a lot of more tests to look at. Then thalassemia screening is something that we all need to do because this is part of standard guideline now to do an HP electrophoresis and even in world also. So your UK, NICE guidelines all talk about doing HP electrophoresis for all. So that's very important to do. Other important is to do thyroid screening for all. Again, this was earlier not done as a standard of care, but now everybody should have a thyroid TSH as well as free T3, free T4, because hypothyroid again can lead to more miscarriages, more malformations, and also we need to look at the thyroid for later on preeclampsia and IUGR. Then our baseline infections are required, HPS, HIV, HCV, then syphilis. These are done for all the patients. And also a urine culture because we want to rule out asymptomatic bacilluria. So these are basic investigation we do for all for the mother. And now I want to send for a viability scan. So we want to confirm that there is a pregnancy and that the pregnancy is inside the uterus. So it has to be intrauterine, not ectopic pregnancy. Then there could be twin pregnancies now with IVF and all the infertility treatment. We get a lot of twins and triplets and quadruplets and quintuplets also. So you need to know how many fetuses there are inside. Is there a heartbeat? So viability. Then this is the best scan to assess the dates. So if the patient is not sure of dates or the cycles are irregular, you need to confirm it by the first trimester scan. Between about 6 to 9 weeks is one dating scan which we require, and any other fibroids or adnexal masses which are present. So for a low risk patient also we will do all these, and for a high risk also we will do this as your basic scan and a basic blood test that we do. And all of them is then given folic acid. Ideally should have been given pre-conception. So yes, if the patient comes pre-conception, we give folic acid before that. But if she comes first time in the first trimester, then we'll give folic acid at that moment of time. So we need to tell her about smoking to stop, alcohol not to have. This in India may not be so much of a problem, but yes, that needs to be understood. What diet to take, how to change their lifestyle. So basically, these are the tests that we will do in all pregnancies. And in high risk, we will go, as we go further with your questions, we will talk about what tests to do later.
Right, ma'am.
Mhm.
So, what factors contribute to categorizing a pregnancy as high risk, and what defines high risk pregnancy in terms of genetic factors? So, first, Dr. Vipaskar, you can tell me about the genetic factors, and then Dr. Vandana can um, lay stress
Okay.
on other factors.
Yeah. So there are multiple factors, including maternal, fetal, genetic factors, and socioeconomic and environmental factors. So when I talk about genetic factors, family history of genetic disorders, a known family history of genetic conditions, which increases the risk of passing these disorders to the offspring. And consanguinity plays a major role. Marriages between closely relative individual can increase the likelihood of autosomal recessive genetic disorders due to shared genetic mutations. And in addition, career status is very important. Parents who are carrier of a specific genetic mutations like cystic fibrosis, sickle cell anemia, can have a higher risk of having affected children. Coming to socio-economic and environmental factors, access to healthcare, that is very important, which generally is not available to everybody. And that too, the high throughput test and limited access to prenatal care and healthcare services, it will definitely aggravate, or complicate the pregnancy risk. Apart from that, there are other environmental toxic which people get exposed to, exposed to harmful chemicals, pollutants, and radiation can adversely affect pregnancy outcomes, including stress and mental health, which is high level of stress nowadays. You must be, the kind of life that we are dealing with or going through, and the poor mental health can impact pregnancy. And it will increase rather complications.
Right. So, Dr. Vandana, would you like to tell some more factors which can lead to high risk pregnancy?
So Dr. Bipaskar has very rightly said that genetic disorders are something which the parents may not even know that they have in their family. So you actually need to have a genetic counseling to find out what disorders are present in that family. They may just come and say, no, there was one baby with mental retardation, वो पानी ठंडा पिला दिया था इसलिए हो गया उसको. So certain things like that. So you need to find out those genetic disorders. But generally, for any other pregnancy that we look at, we kind of divide them into maternal and fetal mode. In maternal, there could be disorders which are inherent in the patient. Like if she is elderly, that's the major chunk and the most high risk at the moment, because everybody is delaying their pregnancies because of their professional life and all that. So age is a major factor. Other than that, we have, if there is a health condition in the patient. So if she is chronic hypertensive, she is diabetic, she has any other CNS disorder, or she has epilepsy herself, or a renal disorder. So this all history has to be taken out. And actually, these patients need to come preconception, again I would say that. So we would call them as pre-existing health conditions. Then there could be alcohol, smoking, tobacco, all that has to be asked from also. Another disease that we have is obesity. So we were talking about poor nutrition in India. Now it is obesity which is coming up, and a BMI which is more is a major risk factor for high risk for diabetes, for infertility, and then leading on to IVF and other problems. So then what else do we look at? We look at the previous history. So if there is an obstetric previous history of recurrent abortions, we would be worried because they could happen again. Previous stillbirths happening, any neonatal death, then whether that neonatal death was genetic related or not related, we need to look at. If there's a previous child who is subnormal, mental retarded, even autism is something has to be looked at. Then previous baby having growth restriction, or if there was hypertension in previous pregnancy, diabetes in previous pregnancy, maybe all these are all obstetric factors which have, so your previous history sings for you about what is going to happen in this next pregnancy. Then finally we are looking at, maybe it is low risk to start with and it becomes complicated. So you may have a low risk patient who becomes high risk because in this pregnancy she had bleeding in the first trimester, higher risk for preterm. If the cervix is short, she's again higher risk for preterm. If she's bleeding now, look at placenta. Placenta previa is a risk factor which is there in this pregnancy now. She may develop hypertension in this pregnancy, diabetes in this pregnancy. Then they can also be fetal reasons. So if the scan shows baby is small, it is a high risk pregnancy. Twins itself, twins more in IVF, but twins more in, it has become an epidemic now of twins and triplets. So again, it is a big factor for our high risk pregnancies. Then if the fetus has malformations, infections, growth restriction, they all will come under high risk now. So pregnancy from a low risk can become high risk. So it is not that you think that the low risk can be left and the high risk only to be managed. Any low risk can become high risk. So of all of them, the age is most important at the moment of time. Maybe Dr. Vipaskar can add to that if he wants to.
I think you have nicely explained, and there is nothing more I can add. You have explained well.
I think, Dr. Vivaskar, you can tell us about the tests which should be recommended to screen for genetic disorder in high-risk pregnancy, and who needs to do them and when.
Who needs and when?
Yeah.
See, I will leave to Dr. Vandana with regard to double, marker, quadruple marker, which is very important. The ultrasound is a very, vital test, non-invasive and very vital. This is. So that cannot be, complemented to any other test. So apart from that, she will also highlight, I feel, with regard to the chorionic villus sampling, when supposed to be done, and amniocentesis, when she's supposed to do, and which kind of patients need this particular services. But what I will highlight here in this particular, the question that you raised about the different tests that is offered to this high risk pregnancy or this patient, this particular group, I will rather advocate, every pregnancy nowadays, but I will advocate that recommended test for NIPS, non-invasive prenatal screening, and it should be recommended for women over 35, those with a history of chromosomal abnormalities, abnormal ultrasound findings, or abnormal results from first or second trimester screening test that we do. When it should be done? As early as 10 weeks of gestation. And what it involves. So a test that is a blood test analyzing cell-free fetal DNA in the maternal bloodstream to detect common chromosomal abnormalities like trisomy 21, Edwards syndrome, that is 18, trisomy 18, and Patau syndrome, that is trisomy 30. But apart from that, sex chromosomal abnormality also we can get the informations like Turner, Klinefelter, and triple X, and various other sex-related gonosomal abnormalities. But now what I see that companies, they actually always, propagate that we do everything. But we have to see the American College of Obstetric Gynecology guidelines and various other important guidelines, what is recommended. So the recommended guidelines, they say it should be recommended for screening aneuploidy. Hope Dr. Vandana can elaborate on this, but I'll just finish the other various tests that we offer for high risk pregnancy, like pre-implantation genetic testing, where it should be recommended for couples undergoing in vitro fertilization who have a high risk of genetic disorders due to age, family history, or career status of specific genetic conditions. And when we should do? During IVF process, before embryo implantation. And what it involves? It involves testing embryos for genetic disorders before implantation to prevent the transmission of specific hereditary diseases. Now, also I felt that I should highlight on expanded carrier screening. Why it is important in this particular platform. So this is actually, we generally do, or it is recommended for couples planning for pregnancy, especially if they have a known family history of genetic disorders or belong to a high-risk ethnic group. So when it should be done? Ideally, it should be done before conception or early in pregnancy. And what it involves? Screening parents for multiple genetic disorders and to assess the risk of recessive genetic conditions in offspring. So I'll just ask Dr. Vandana to take over the rest of the part.
So basically, we are high-risk pregnancy specialists. So it is for anyone who is pregnant, we do a basic screening test. So our basic screening test starts with our NT scan. So NT scan means nuchal translucency. Nuchal means the neck and translucency means the thickness. So what Nicoloides saw is that those babies which had Downs had a small nose and a thick neck. So that is how this nuchal translucency and nasal bone came up. So every pregnancy after a viability scan gets a nuchal translucency scan done. And it is the standard of care all over the world to do this. So it is a very standardized position that you need to do it only between 11 to 13 plus 6 weeks. That is the time period when you look at the thickness on the back of the neck in a very zoomed up image, mid sagittal. It is very standardized and you measure the nuchal translucency. So if this nuchal translucency is in the normal centile, then we are little reassured. And at the same time, we look at the rest of the baby for the size of the baby, look at all structures. So nowadays with better resolution ultrasound, we can even actually see most of the things at 11 to 14 weeks. So you would be able to see the brain and the stomach and the heart, spine, limbs, hands. All these things can also be seen at this moment of time. So with this nuchal translucency, we do what we call as a dual marker test. So dual marker means two things. So two things means it is for PAPE and beta HCG. So your age plus the NT plus the biochemical PAPE and beta HCG is total called as first trimester screening. And it is a screening for Down syndrome majorly, but we would also look for trisomy 18 and 13 as well. So this is a screening test which is done for everyone, young and old. So it is even for 20-year-old also, you'll do a dual marker with an NT scan combined called as first trimester screening. It has a detection of as much as 94-95% for Down syndrome screening. So it is standard that we do a screening test for all. The risk is more as the age increases, but this screen is for all. But it is not possible that all patients will come in that 11 to 13 plus 6 weeks. So if a patient comes after 15 weeks, then do we offer them anything else? We still offer them what you call as a quadruple screening test. So quadruple means 4 things. So it has got 4 biochemical things. So your age combined with the AFP plus beta HCG plus unconjugated estriol plus inhibin. So there are 4 biochemistry plus the age plus the scan. You get again a risk. So you get a risk of Down syndrome or a risk for trisomy 13 or 18. So this risk, if it is 1:250, we would call it as low risk. And if it is higher than this, we would call them as high risk. So if they are low risk or high risk, either a dual marker or a quadruple marker. We don't do both the tests. We do only one of the screen tests. And if any of these comes positive, then we do a more diagnostic test. So diagnostic test would mean either a chorionic villus sampling, which is done again 11 to 14 weeks, where we take sample from the placenta. And the ones where quadruple marker is positive is after 16 weeks, we would do an amniocentesis. We will talk about them as we come further. So once this is done, our next scan is at anomaly scan. So anomaly scan is our 18 weeks to 22 weeks. This is the time for looking at all the structures of the baby. So we call it as a genetic sonogram. So you mean that I want to look at all the structures and understand whether there is a genetic disorder or any other structural disorder which may impact the baby's life. So we would look at all the brain, heart. For heart, we would also do an echo for high risk. For low risk, we would do a good cardiac scan is what we want to do. And look at rest of the growth and the placenta, cervix. So ultrasound is an important test. As sir said, NIPS is a good test because its detection is almost 99% for Down syndrome. So where the patient can afford it, or if your dual or quadruple marker comes as positive, but the structure of the baby is normal, maybe there I would advise NIPS, and it's a very good test, but it should be correctly used, not used for everyone and do a screening of NIPS for all of
Yeah, that is what I wanted to highlight, that it should be done on the high-risk pregnancies.
Yes.
Not that every woman who just comes with pregnancy, and it should not be a practice of, doing simply some test
Yes.
for no reason.
Yes.
So, Dr. Vipaskar, can you tell us what are the primary genetic disorders screened for during high-risk pregnancy, and how is this prenatal genetic testing or screening important in high-risk pregnancy? Dr. Vipaskar?
Yeah. So the primary genetic disorders that are screened for during the high-risk pregnancy includes chromosomal abnormalities like Down syndrome, same thing like trisomy 18, and Potout syndrome like trisomy 13. And other conditions commonly screened include beta thalassemia, neural tube defect, which we call it spina bifida, cystic fibrosis, sickle cell anemia, hemophilia. And this screening test may also focus on detecting specific single gene disorders. If there is a family history, known family history or career status. So it is just like a universal prenatal screening generally. That is mostly the gynecologist or high-risk pregnancy specialist, they screen. So this is prenatal genetic screening or genetic testing is the best strategy for reducing the burden of genetic disorders and congenital abnormalities or disabilities. So it is like, prenatal screening also is very vital in high-risk pregnancy because it enables the early detection of genetic and chromosomal abnormality. Genetics means it could be anything, single gene, it could be multifactorial, polygenic. Because nowadays people suffer with hypertension, diabetes more, cancer. So I'm just including, you don't think that genetic means just monogenic. It is not just single gene disorders. So this early detection of genetic and chromosomal disorders, abnormalities will be picked up. So early detection will be helpful. It allows healthcare providers, that is the doctors who are treating the patients, to offer appropriate intervention, including counseling, management options. And screening, this genetic screening, it helps expectant parents make informed decision, about their pregnancy, including considerations for specialized care and further diagnosis testing. There are advanced diagnostic testings are also available. Techniques or test facilities are available, which can be thought of, like digital PCR, NGS test, and various other tests. So, and potential treatment and preparations for managing a child with a genetic disorders. So these are very important, and it should be like a general, it is like a universal prenatal screening practice. Generally we do, and Dr. Vandana probably will highlight better. She is going through a lot of interesting cases. Even she has solved very interesting cases of mine, which because of time scarcity we cannot deviate, but probably she can elaborate.
Sir, I think the geneticist and the obstetrician have to work together, because what patient comes with is, my child has got a disorder, do a karyotype test. So it is not that. You first have to find out in the first child, in the index child, what is the problem, because you can't do a CVS or amniocentesis or an invasive test without knowing what the previous child has or what is there in the family. So it is both collaboration of the geneticist and the fetal medicine and the obstetrician to work together, and then only we'll be able to find out the disorder in the patient. So
Thank you.
when you are saying these genetic disorders, yes, we screen for all this. Then we look at structures. So your neural tube defect is very common in India with the deficiency of folic acid. And the third thing, very important, is hemophilia. I think we should not have even one child born with hemophilia, but it's a huge burden at the moment in India.
Thank you.
Right. I would definitely like to know from you, ma'am, that how preeclampsia is managed in high-risk pregnancy.
So preeclampsia is a high-risk pregnancy. So you need to first define the risk factors for preeclampsia. So all those where you are advanced maternal age or diabetic earlier or chronic hypertensive earlier or recurrent abortions or IVF or twins, they are all at high risk for preeclampsia. So those who are at high risk, the first thing is to do prevention. So the risk of preeclampsia is almost 10% in the general population at the moment. Aneuploidy is 1%. This is very high. So your preeclampsia, first you try to prevent, and before preventing, we want to predict. So if I want to predict preeclampsia, one is by looking at these risk factors in our history. If they are there, then I'll be little worried that this patient may develop hypertension later on. Or otherwise, we do a screening test. So this screening test again is done in that NT period. So that 11 to 13 plus 6 weeks, when we are doing an aneuploidy screening by that first trimester, PAPE, beta HCG, if I do a uterine artery PI, uterine artery Doppler, that is, uterine arteries are vessels which are going to the placenta. They will tell us about the risk of preeclampsia. So our uterine artery with the age, with the risk factors, with mean arterial pressure, and PAPE and PLGF. So this is a test which is similar to first trimester. We just add on one PLGF and we add on a uterine artery. It will again give us a risk for preeclampsia. Like how a risk for aneuploidy is there, we also get a risk for preeclampsia. And if it is more than 1:100, then I would tell the patient you have a chance of developing hypertension later on. So what I can start for is I can start her on aspirin. So aspirin is a tablet which has very less side effects and it will prevent 80% of preeclampsias. So from your this lecture, maybe you can patients need to understand that this test is very, very important nowadays, so that I will prevent 80% of all those who will develop preeclampsia by just a small tablet of aspirin of 150 milligram. So that is started at the 12 weeks of gestation, and then we continue it till 36 weeks of gestation. But we will still continue to monitor these cases. So after we do this preeclampsia prediction, then we do our anomaly scan where we look at all the structures, and we will follow them up for blood pressure. So if I am able to prevent preeclampsia, aspirin continues and we go until term. But in case there is development of hypertension, so then I need to define it as blood pressure of more than 140 systolic and a diastolic of 90. So if the BP is more than 140 and diastolic more than 90, I call it as mild preeclampsia. If it goes from 140 to 160 and diastolic to 110, I will call it as severe preeclampsia. So you divide it into mild and severe. And this was associated with proteinuria. So then we will call it as preeclampsia. If it is not with proteinuria, then it is gestational hypertension. But if a patient develops headache, blurring of vision, thrombocytopenia, liver functions derange, renal function deranges, then also they are called as preeclampsia. So it is blood pressure with symptoms is called as preeclampsia. So these symptoms, patient has to be informed that you are at high risk. So if any of these symptoms are there, then you come back to us. Otherwise, we monitor them more frequently. That time I said low risk, we will just see them at 20 weeks and then we follow up at 26, 30 weeks. For those where we have high risk for any other disorder and preeclampsia, I will monitor it maybe every month or even more frequently if we start them on antihypertensive. So anytime our BP goes beyond 140/90, we will start them on antihypertensive. Previously, we used to start only when it becomes severe, but the new guideline is we should start as soon as we see the BP of 140 and 90. So labetalol and Nicardia and oral tablets are also available, but if there's severe hypertension, IV is also available. So if you have blood pressure, the blood pressure needs to be monitored. These patients have got babies which become growth restricted, and the blood supply also can come down. So after that anomaly scan, I will start doing their color Doppler. So all these patients with hypertension, we start doing ultrasound at about 26 weeks of gestation to see the growth, look at the Likert, do a blood supply assessment, that is Doppler we call it, and we monitor them further. So monitoring is both for the mother as well as the fetus also in hypertension. So anytime the blood pressure becomes very high or the baby is having growth restriction or Doppler changes, we might need to deliver them early. So we will need to decide when to deliver depending on how it goes on. So these babies which we deliver early will have not so much of, they are premature. So for prematurity, you need to give them steroids. Steroid is given for lung maturity of the baby. So if the baby, we are planning to deliver her before 34 weeks of gestation, we give 2 doses of steroid, which is a boon for the baby because the lungs get better matured and they can be managed better in the NICU. And additionally, this is a new drug is Maxel, magnesium sulfate. So it was earlier given for severe preeclampsia, but it also helps for brain neuroprotection. For the baby hemorrhage, it helps in. So any baby which delivers before 32 weeks of gestation, steroid and Maxel. Maxel also needs to be given because the risk of convulsion, risk of hemorrhage in the baby is less. So when to deliver will depend on the obstetrician. So these patients need to be managed in a tertiary care center where you have facilities both for the mother, for ICU, physician, and neonatology also. So you need a good setup for managing these high-risk severe preeclamptic patients.
Just to ask Dr. Bandana, anything is given for epilepsy during this period?
So Maxelf is again not epilepsy, it is a convulsion because of eclampsia. So we call it as eclampsia. So for them, we give Maxelf. So we will only give when there is severe headache, blurring of vision, epigastric pain, or the BP is very high, or the proteinuria is very high, then to tide over impending eclampsia, we call it, we would give them Maxelf. So Maxelf is Indian origin Maxelf. The scientist who developed this prevention of eclampsia was an Indian. Maxelf. Very low cost, but very useful drug.
Effective.
Because of time shortage, I'll have to ask the concluding question. And so the concluding question is to both of you. First, Dr. Vivasur can address it, that how does understanding both genetic and gynecological aspects improve the outcome of high-risk pregnancy, and what role do geneticists and gynecologists play in this process?
Sir, you can take it.
Okay, understanding both genetic and gynecological aspect is very crucial in improving outcomes for high-risk pregnancies, because it allows for comprehensive care and tailored interventions. So geneticists plays a very pivotal role by conducting risk assessments, performing genetic testing, providing counseling to identify potential genetic disorders such as Down syndrome, cystic fibrosis. Down syndrome is just numerical chromosomal abnormalities. Cystic fibrosis, when it comes, or thalassemia, beta thalassemia, any other disease, it comes single gene disease. So it covers everything, not only just single gene or chromosome or multifactorial. So as a whole, during early in pregnancy. So this helps in making informed, decision, which I told before also, and planning for necessary interventions. On the other hand, gynecologist who focuses on monitoring the pregnancy through her regular exams, ultrasounds, managing and gynecological, various complications, like she explained about preeclampsia or placental previa. They make that they ensure there is a safe delivery. I will not enter into this aspect. I just touched upon, but now Dr. Vandana should elaborate on this.
So I think, let me put it this way, that when a patient comes to us, she comes with all the energies, thinking everything is going to be beautiful and the baby is going to be good and everything is going to be perfect for her and she'll get a perfect child. But there could be problems of expectations, and suddenly you come up with some disorder that comes on the scan or on the dual marker, or some genetic disorder which has been told. So when there are these broken expectations, I would call them, it is all of us have to work together so that we give them a good child. So we can't be obstetrician working alone. We can't have only radiologist and fetal medicine working alone. We need to have the geneticists on board. We need to have pediatricians, pediatric surgeon, pediatric cardiologist, all of us together to work. And we also need a good obstetric team and a good neonatal team all together when we are looking at these babies with broken expectations. And so we have to give them the best that we can provide to them. So if there is a disorder which is an anomaly that we have, then let us see whether it is genetic. We can test on that. If it has got something, we can correct it with time. We can do that. Some interventions we do in utero also. I'm a fetal medicine intensivist, so I do a lot of interventions inside for some structural abnormalities, for other things. And in case it is something which can be managed postnatally, then let us take it till term, bring it out in a good condition, and let the pediatrician and the pediatric surgeon manage it. So I think it is what your question finally is, that we have to all work together to get the best out of, for the mother as well as for the child also. That is what I would like to say, and there should be policies in place for all this.
Right. So thank you all for joining us today for this critical discussion on managing high-risk pregnancy and the role of prenatal screening for genetic disorder. Thank you, Dr. Vanna. Thank you, Dr. Vivaskar.